Afternoon, everyone, and welcome to the Lynn Cancer Institute updates for 2025. This is important information for everyone from our physician panel series. We're very grateful to have you all with us today and to learn about melanoma and skin cancers from our amazing speakers, Dr. Ann Reed, Medical Director of Skincare Research at the Rendon Center for Dermatology, Dr. Michael Casper, Medical Director of Radiation Oncology at the Lynn Cancer Institute, Dr. Lloyd Berkowitz, our medical oncologist, and Dr. Harold Huss, our surgical oncologist, both at the Lynn Cancer Institute. At the Lynn Cancer Institute, we believe that education and awareness, prevention, screening and early detection, a variety of treatment options, our latest technology, and the expertise of our amazing staff, as we're seeing today, the benefit of our multimodality method of treatment, all combined will truly save lives. In the interest of time, each speaker's bio was sent to you by email. We invite you during this presentation to take notes, and if you have any questions, please jot them down in either the chat box or the Q&A box, and we'll have time at the end of the presentation to address those questions. We're very proud to welcome you today and to introduce our first speaker, Dr. Ann Reed. Dr. Reed?
And mute myself. Hi, everyone. It's so good to have you here. Thank you for logging in. This is the month of May, and May is Skin Cancer Awareness Month. So I'm very happy to be here to discuss skin cancer and skin cancer prevention with this wonderful panel of great physicians. So let's get started. So hopefully you can hear me and you can see my slides. So there are many different types of skin cancer, and we will review the top 3 most common types of skin cancer: basal cell carcinoma, squamous cell carcinoma, and melanoma. But there are others, such as cutaneous T-cell lymphoma, dermatofibrosarcoma protuberans, Merkel cell carcinoma, sebaceous carcinoma, and there are others, more rare types of skin cancers. These are photos. This is Teddy Mellencamp, who recently is in a battle with metastatic melanoma. And she is posting her course and her story and everything she's going through. So, people may know about melanoma from her. And then Jimmy Buffett over here that recently had passed from Merkel cell carcinoma. But what these two people have in common is that they're increasing awareness for skin cancer. So I can say I have seen more patients in my office who have mentioned these two celebrities and came to get a skin check because of that. So let's get into basal cell carcinoma. It is the most common type of skin cancer and typically develops after years of sun exposure or indoor tanning. Typically found on the head, neck, and arms, but we can really find them anywhere. It looks like a pink or skin-colored round bump that's kind of shiny. So if you can appreciate these photos on the right, they have this sort of shiny pearl-like appearance. They can also look like a pimple that doesn't heal. Or it can be a superficial type at the bottom that just looks like a flat pink patch of skin. When caught early, they are extremely curable. And if they are not caught, they just continue to grow and grow, and they can cause disfigurement. These are photos of basal cell carcinomas I've found in my office. And so they can look like various, many different things. The main idea is if you see something that looks funny to you, go get it checked out. Squamous cell carcinoma is the second most common type of skin cancer. It is usually found in sun-exposed areas, although you can get squamous cell anywhere in the body. But neck, face, rims of the ears, arm, chest, back. It looks like a red, firm bump that typically has a scale. It can also be a sore that heals and then reopens and heals and reopens. And that, like a wound that doesn't heal, is something you'd want to show to your dermatologist. It can grow deep into the skin. It can metastasize. It can cause damage and disfigurement. So again, early diagnosis and treatment can prevent these from growing deep and spreading. These are just some photos of squamous cell carcinoma on the hand. This is an excision of a squamous cell carcinoma in the office, and then a squamous cell carcinoma in situ on the back of the left arm on the right. Melanoma is the deadliest form of skin cancer because it has that tendency to spread and metastasize. It can appear as a dark spot that looks different than the rest, which we call the ugly duckling sign, or it can develop within a mole that you already have, and that existing mole starts to change, look different. Definitely want to bring that up to your dermatologist. So, early diagnosis of melanoma is crucial. The 5-year survival rate in a very low stage melanoma or melanoma in situ is significantly higher than, stage 2, stage 3, stage 4, obviously. So knowing the ABCDEs, which I will go over and teach you, can save a life. If it's yours or your significant others, they have a mole on their back that looks very different and they can't see it. Those are things you're going to want to look out for. These are examples of melanoma I found in my office. I'm sorry that the photo quality isn't the best. The obvious black spot, but it can also be just a lighter spot that's changing. We also have signs of regression where you get like a halo around your mole, and that's your body trying to get rid of it. That should be a sign to get checked. And these are dermoscopic photos below. So the physical photo at the top is what you see, and the dermoscopic photo underneath is what I see with my light. There are different variations of melanoma. So we can get nail melanoma, amelanotic melanoma that could just be a pink patch or a pink nodule, and then again, ocular melanoma that is rare but can definitely happen. Merkel cell will review a little bit. It is a rare aggressive cancer that grows in the outer layer of skin. It's almost always a pink or red bump or nodule on the head and neck that grows quickly and has a high risk of spreading and recurring. 80% of them are caused by a virus called Merkel cell polyoma virus. 20% are caused by UV radiation. Unfortunately, we rarely find these at an early stage. They do advance rapidly. There's Jimmy Buffett on the bottom right. Unfortunately, he did have one that was caught, but unfortunately, he did not survive. There are recent immunotherapy medications that are improving survival rates in all of including melanoma, Merkel cell. We are seeing new immunotherapies come out that are really helping with survival rate. So the ABCDEs is what I had mentioned prior. We're going to review it quickly. The left column is benign lesions, and on the right, these are malignant melanomas. A stands for asymmetry. So if you have a mole that's round, it looks nice and, circular. That's a benign feature. If you imagine cutting it down the middle and folding it in half and you can't match both sides, that's asymmetry. B stands for border. If there is an even border, that's great. Uneven borders, meaning notched borders or scalloped borders, that's a sign of atypia. Multiple colors, so that's the C. 2 or more colors are going to want to bring your eye to that mole and have it checked. Diameter, so if it is smaller than 6 millimeters, there is a higher chance of it being benign. If it's larger than a pencil eraser or 6 millimeters, the chances are a little bit higher of that being a troublesome mole. E stands for evolution. So this is not what we see. This is what the patient tells us. So let's say you had a mole, it looked like the one on the left, and now all of a sudden it's changed in size, in shape, in color. It started itching. Now it's bleeding. Those are things you're going to want to get checked. So when I say ABCDEs of melanoma, this is what I mean. So how do we screen and how do we diagnose? So this is me in the office with my dermatoscope. You come in for a skin check. We sit you down. I check, head to toe, all of your moles. There are many ways to diagnose skin cancers, the most common way is a biopsy. There are three different types, a shave, a punch, or an excisional or incisional biopsy that you see the photos at the bottom. Just anything to get a sample of the skin and have it checked with dermatopathology and analyzed. There is dermoscopy, which is the device I'm holding up to my face in that photo, and that helps us pattern recognition. It helps me see little features that we can't see with the naked eye. There is something called reflectance confocal microscopy. Some offices do carry this, and this allows us to see into the dermis and under the epidermis without physically cutting the skin and checking patterns in nevi or moles that are starting to change. You can check without actually removing a piece of tissue. There is genomic testing where we get either beforehand or afterwards risk assessment. And then newer advanced technology devices powered by augmented intelligence, we're going to start seeing in the future of little devices and sensors and things that will allow us to analyze through spectroscopy whether or not these lesions are at risk or match features of skin cancers. So the best thing we can do is prevent, right? So I know that when I was in college, going to the tanning booth and having a tan was very cool. And what we've learned, or what I've learned, is that basically you're selecting which cancer you want. So basal cell squamous cell or melanoma. There is no good tan. There is no good base tan. All tans are sign of sun damage. The majority of skin cancers are caused by UV radiation, so we want to avoid the sun at peak hours, especially here in South Florida. If you're going to go to the beach, enjoy yourself, but try to seek shade, have an umbrella, wear your broad spectrum sunscreen, minimum of 30 SPF, as well as sun protective clothing. The bottom left is a photo of my youngest son, Mason, at the beach. So we do go and enjoy ourselves, but he's got a hat, he's got sunscreen, he's got his sleeves on, and we're reapplying exposed areas after he goes swimming or if it's been more than 2 hours. Children and adolescents need to be protected from excessive sun exposure. Most of our sun damage is before the age of 18, and that can significantly increase our risk of melanoma. This is a really interesting photo to me. It's from the New England Journal of Medicine, and this is a truck driver who drove for many, many, many years, and on the left side got significant sun exposure, and you can see the difference in the age of his skin. We call this dermatoheliosis. So this is a perfect example of why wearing sun protection is important. And even when you're driving, you do get sun through those windows. So get your tints on your car, put your sunscreen on. There is no tan. That's good. Like I said, it means DNA damage. And obviously, besides preventing skin cancer, you want to prevent aging. No one wants to look wrinkled. So let's put our sun protection on. We're getting towards the end of my lecture here. This is just helpful for prevention. I discussed this last year. Nicotinamide is a powerful vitamin. It's vitamin B3, and it has been shown in clinical trials to help reduce skin cancers and precancers called actinic keratoses. The study showed if you take 500 milligrams twice a day, you do have a 23 or 24% reduction in actinic keratoses. You can find nicotinamide naturally in poultry, fish, eggs, and nuts. So eating colorful foods that are orange or red hued can actually protect your skin. And this fern plant that you see here is called Polypodium leucodermis, was discovered in the Amazon in Brazil. And they actually put it into a vitamin supplement form. And so you can take an oral capsule of Polypodium leucodermis, and it will protect your skin from oxidation, free radical damage, temporarily. So anytime I'm going to the beach, I'm going on a cruise, I will take this about an hour before I head out, and it's not prescription, completely natural. I don't get paid to talk about it. I just think that it's something that's quite advantageous for my patients. And that's it. Thank you so much for having me. I hope you learned something, and I'll be here at the end if you have any questions. And you can find me at the Rendon Center. I also run clinical trials through skincare research here in Boca Raton.
Thank you, Dr. Reed. Dr. Casper?
Okay, can you see my slides?
You're on the preview side. If you go up under display settings, you can flip it. Yep. There you go.
Perfect. Okay, thank you, Dr. Reed. That was outstanding, and I did learn something. Thank you so much. Today, I'm going to speak a little bit about radiation therapy and radiation therapy in the treatment of skin cancer specifically. So first, I wanted to just tell you a little bit about radiation, because many patients come in and they're afraid of radiation. They've never had radiation, and they really are just afraid of proceeding with treatment. I'm having trouble switching my slide for some reason.
Make sure your mouse is double clicked on the picture.
There we go. So radiation, despite being the single most utilized agent in treatment of cancers, and despite being very curative and cost effective, it's often underutilized. A lot of patients are afraid of it, as I said, and even some physicians don't have a strong background or understanding of radiation. So for that reason, I think sometimes it's underutilized. And it's important to note that even small changes in radiation delivery can have a large clinical impact. Changes in the technique, the dose that's chosen, the field size, basically expertise. Like any area of medicine, you can say that, but I think it's particularly true with radiation. Oh, I'm going to go back one. I don't see an arrow. Can we go back one? Let's see. There we go. Got it now. I found it. So one of the things I wanted to point out about our program is that, and it really sets us apart, is that we have multimodality cancer clinics, and specifically we have one for advanced cutaneous malignancies, which I think is fairly unique. There are a few across the country, but not many in hospitals like ours. And at these clinics, we have experts in skin cancer getting together, including Dr. Huss and Dr. Berkowitz, representing medical oncology and surgical oncology. Usually the patients are referred in by dermatologists like Dr. Reed. There's a radiation oncologist that focuses on skin cancer, usually me, who's at this clinic. And we all see the patient at the same time. And get the history. We have a nurse navigator who pulls in the information, usually the path reports and imaging studies if they're done, and we're all seeing the same information. And that's truly the state of the art as far as cancer care goes for any type of cancer, but skin cancer in particular, it's usually difficult because people go to dermatologists at different times, different places. Some of our patients are being seen up north, and it's difficult to all be seeing the same imaging studies and pathology slides. But for the most part, we try really hard to get that done, and we do a good job of it. It makes a big difference in the treatment recommendations, and I think it sets us apart. So now I want to show you a few of the patients that we see. Unfortunately, a lot of times patients are sent to us as an afterthought. This was a 100-year-old lady who, they figured this wasn't bothering her so much. How long is she going to live? But unfortunately, it did progress. She was very bothered by it. And they finally said, well, radiation, can you help with this? And we've seen many patients like this. These are fairly run-of-the-mill. At any one point, we have patients like you're going to see under treatment. This was after about 4.5 weeks of treatment. You can see she's had a complete response from the radiation. We put in an eye shield to protect the eye. Sometimes there's some issues with the ducts. The ducts can close up, but usually that might result in some tearing. But for the most part, patients do very, very well, and they have a great result. Here's another lesion we treated in a patient. She had 16 treatments to this lower lip lesion. These are very painful frequently. We put a shield behind the lip, as you can see. The radiation is fairly superficial for most skin cancers, but for something like this, we have to use a slightly deeper radiation to go through the entire thickness of the lip. So we put a lead shield behind the lip as well to protect the teeth and the gums. And another lesion that we have seen, this is another elderly patient who was felt to be a poor candidate for surgery. She had 6 weeks of treatment. This was shortly after, this was 6 weeks after 3 weeks of treatment. You can see she's almost completely healed, and usually something like this will completely heal in a couple of weeks. Another lesion of the ear. This is about 5 months out. The ear was somewhat compromised by the cancer. There was a little bit of destruction of the cartilage. It went all the way through the ear, and this patient had 5 weeks of treatment and ultimately did very, very well. And here's another case. This was a gentleman who was sent in for palliative radiation. This was just to try to control the oozing and bleeding. You can't really see that here in this case, but it was a management issue because the patient was having a lot of bleeding and this smelled, and they wanted something to be done and asked, do you think we can help with this? And this was after just 3 treatments, 1 week. Usually we can get a response. The challenge is if you treat too quickly, sometimes you're not going to get good healing, and you would need, for long term, you'd want some plastic surgery closure or some sort of, assurance that the patient's going to have healing. Particularly in the legs, there is poor blood flow, and healing can be an issue. But in this case, it was just a wound management issue, and like I said, it was palliative. The gentleman didn't have long to live, and this made it a lot easier for them to control this and cover this lesion, and it actually was less painful as well. So we have in the radiation department, in a real radiation center, we have multiple tools for curing skin cancer. We can use standard X-rays, which are photons. We use particles, usually electrons, which can be specified to a certain depth. So we can have these be very superficial. There's high dose rate brachytherapy, which we often use because that gives us much tighter margins, and we can control the depth and treat usually with fewer treatments than standard X-rays or electrons. And frequently used today, you'll see superficial X-rays. These are marketed heavily. This is the Gentle Cure you'll see, or the SRT 100 that's often out there. This is not really new. We've had superficial X-rays that we've used in radiation and in dermatology since the 1935, 1940 era. Superficial X-rays were discovered and used, but now it's put together in a nice, concise little package, and it's popping up in a lot of different offices. So it's used. The difference is it's not appropriate for all cancers. You have to really assess and have an experience to know what depth you can treat with the superficial X-rays. Most early skin cancers will be appropriately treated, but you have to be careful, and sometimes you can assess the depth with ultrasound. Dermatoscope is helpful, like Dr. Reed was talking about. That can be very helpful for radial margins. But if it's something that looks a little bit deeper, we're probably better off with high dose rate brachytherapy, where we can specify the depth. We can specify to 1 millimeter, 2 millimeters, 3 millimeters once we assess the depth, and we can do that with ultrasound or CT scan. Here's some of the technology we have. I won't spend much time on here, but we have a lot of different types of machinery that gives different types of radiation. And most of these are utilized, except for the ViewRay Meridian. We wouldn't use that for skin cancer. We also have a proton machine, except for deeply invasive skin cancers, we probably wouldn't use that either. But many of these other machines we certainly could use for skin cancers. Here's another very interesting method that we have. This is a Freiberg flap that we use with these catheters that can be very, very specific in how they deliver the radiation. And we use this very frequently for larger tumors or curved surfaces. And these are the small applicators, like the Leipzig applicators. They are these tungsten steel applicators with the source sitting right in the middle and deliver a nice cone of radiation, which is very, very well demarcated, so we can use tighter margins. And last time, I think I started off with some discussion about Mary Curie, and then going through this talk, I saw this cute little picture of her with her husband, and I couldn't resist ending with this because she's had done so much in the world of radiation and cancer care. So thank you very much, and we'll turn it over.
Thank you, Dr. Casper. And now we have Dr. Berkowitz with medical oncology.
Welcome, everybody. Thank you for joining us this afternoon. I'm going to talk about systemic therapies for malignancies of the skin, which has really been an area of intense improvement over the last 15 to 20 years. So how do we use systemic therapies for cutaneous malignancies? The most common application is in patients who have metastatic or spread of their cancer or locally advanced disease, where the treatment is not amenable to surgery or radiation therapy. We also do what's called adjuvant therapy, which are treatments given after the primary tumor is removed or radiated to reduce the risk of future recurrence. We also use the term neoadjuvant therapy, and there's some data, and I'll show you a little study design a little bit later, where therapies are given before surgery or radiation therapy to improve the eventual complete eradication of tumor. So when we talk about locally advanced metastatic cancers, there are a number of therapies that have been used. I am very, very happy that I don't have to prescribe interferon or interleukin anymore. These were the earliest immunotherapies, very difficult for patients to tolerate, and with lots and lots of side effects. And I'm glad I never have to prescribe that anymore. The new immunotherapies, you've probably seen commercials for Keytruda or pembrolizumab. We also use Yervoy and Opdivo in many of our skin malignancy treatments. As far as chemotherapy is concerned, the earliest chemotherapy for melanoma was a drug called dacarbazine, with the oral equivalent being temozolomide. If you look at the data, there's only a 10 to 20% response rate in those patients, and that is not a cure rate. Those are just partial temporary responses. For patients with melanoma, about 25% of them will have what we call a BRAF mutation. And those patients who have BRAF mutations, we now have 3 FDA-approved BRAF MET combinations of oral chemotherapy drugs, which can be quite effective. We also have chemotherapy for locally advanced or metastatic basal cell cancers called hedgehog inhibitors. The most common one is a drug called Eravage. And as Dr. Reed mentioned, we do have immunotherapy now for Merkel cell cancer. Avulimab and Keytruda are 2 of the most common ones that we use. So I talked a little bit about adjuvant therapy. We're often asked to, in patients that Dr. Huss will operate on, where we determine that there's an increased risk of metastasis going forward, we're often asked to apply adjuvant therapy to reduce the risk of recurrence. The earliest adjuvant therapy was high-dose interferon, which is a really difficult 1-year treatment. And now that the data is very mature over 25, 30 years, we realize that even though we put patients through an incredibly difficult year of treatment, the actual reduction in recurrence rates was quite modest, quite small. We now have approval for single-agent immunotherapy drugs, PD-L1 drugs, Opdivo and Keytruda, which are much safer and much more effective. And for those patients who have BRAF mutations, you can also rely on the BRAF MEK inhibition, the 3 approved combinations that I mentioned before. A little bit more toxicity than drugs like Opdivo and Keytruda, but certainly appropriate for some patients. The adjuvant therapy for melanoma we also use for patients who are lymph node positive at the time of surgery. but there are those patients who have metastatic disease that is removed surgically to the point of no evidence of disease, and we offer them adjuvant therapy also. Recently, there's data showing that even in patients who have negative lymph nodes but have large primary tumors, that adjuvant immunotherapy could be of benefit. One quick discussion of neoadjuvant therapy. There was a Southwest Oncology Group study where they took 300 patients with advanced melanoma and two groups of patients. One was surgery followed by post-op adjuvant Keytruda, which is one of the immunotherapy drugs. The second group got 3 or 4 cycles of Keytruda first, followed by surgery, and then followed with Keytruda after. The event-free survival in group A was 49% after 2 years of follow-up, but 73% in those patients in the group that got preoperative immunotherapy. Just want to end with one case report. This is a patient that I took care of after he moved here from Kentucky. In 2015, he had a melanoma on his chest, 2.4 millimeters, lymph node negative at that time, but postoperatively he was treated with 6 months of adjuvant therapy with dacarbazine and interleukin-2. Unfortunately, 3 years later, he developed metastatic melanoma to lung and liver, and he was started on Keytruda, which is a very commonly used immunotherapy drug. And PET scans dating back to 2024 showed a complete remission. He had virtually no toxicity from the immunotherapy other than vitiligo, which is a sort of loss of pigmentation in the skin, which is a very common side effect from immunotherapy. I just want to close with one last thought, to sort of outline how important these new drugs have been for the treatment of skin malignancies, especially melanoma. If you look at the survival data for patients with advanced and metastatic melanoma before immunotherapy and BRAF drugs, the average survival for patients with metastatic melanoma was about 7 to 8 months. Now with these new drugs, the latest data shows that the survival rates on average are pushing up to 7 to 8 years. So it's really a remarkable improvement in survival, and many of those patients are probably cured even though they had long-standing and widespread metastatic disease like the gentleman I presented here. So I've now opened this up for Dr. Huss, who will talk about surgery. And I left him enough time so he won't be mad at me.
Thank you, Dr. Berkowitz. Dr. Huss.
Did you see my screen?
Yes.
So welcome everyone. Thank you for joining today. After Doctors Reed, Casper, and Berkowitz, I'll be talking about surgery for melanoma and other skin cancers, and there's a lot of overlap with Dr. Reed. 1 second. So skin cancer is the most common cancer in the United States. 1 in 5 Americans will develop skin cancer in their lifetime. Almost 10,000 people a day in the United States are diagnosed with skin cancer. That means over 6 million cases of non-melanoma skin cancers are treated in the United States every year. So what do we mean when we're talking about skin cancer? So commonly here are the most common skin cancers that we see. Here's basal cell carcinoma, squamous cell carcinoma. As you can see, can get quite large. Melanoma, Merkel cell carcinoma, adnexal tumors like porocarcinoma, hidradenocarcinoma, and sebasteoma, and many others. Metastatic disease from colon, breast, lung, stomach. Cutaneous sarcomas, including Kaposi sarcoma. And cutaneous lymphoma. How do we treat these skin cancers? Well, there are many different types of treatment: surgery, Mohs, systemic treatment, topical treatments, and local treatments. But today we don't have time to discuss all of the skin cancers, so I'll focus in on melanoma. One in every single hour in the United States, one person dies of melanoma. It's one of the most serious forms of skin cancer. About 100,000 people are diagnosed in the United States every year, with about 8,000 deaths. And Florida has the most melanomas per capita out of any state, with 10,000 cases a year. It's the fifth most common cancer in men and women. And in 2040, melanoma cases will double, and it will be the most common cancers in male. Usually we see melanomas on the back in men, legs in women. It is more common in men. And you could see melanoma almost everywhere, in the skin, the eyes, the intestines, the mouth, and many other places. Only 25% of melanoma comes from moles. As you get older, the incidence increases, and most melanomas are found by patients themselves. The highest rate of melanoma we see in Australia and New Zealand, and that's because of sun exposure. 65% of cases in the world are caused by sun exposure. Survival depends on stage. Early diagnosis is extremely important, and the 5-year survival rates are much better with localized disease than distant spread. So what is melanoma? Melanoma is a type of cancer that comes from melanocytes. These are pigment-producing cells that produce melanin, which give skin its brown color, and it also protects deeper layers from the sun. Most melanomas are confined to the epidermis, the top part of the skin, and they grow radially, and those are very curable. However, once they start growing vertically, like nodular melanoma, and they invade into the dermis, they have significant metastatic potential. The four most common types of melanoma we see are superficial spreading, which are most melanomas. These are thin melanomas. You have thick melanomas, like nodular melanomas. You have lentigo-malignant melanoma, which we see on older people, and acrolentiginous melanoma, which are pretty rare, but we see on the palms, soles, and under nails. And these are the most common melanomas we see in Asian and Black population. Risk factors, like Dr. Reed already spoke about: sun exposure, personal history. If you have a history of skin cancer, any other skin cancer, it predisposes you to other skin cancers. Phenotypic features like fair skin, red blonde hair, light eye color, and if you're immunocompromised. Diagnosis by biopsy, one of these four biopsies. The most common biopsy that I see in my office by far is a shave biopsy in the right upper corner. We know the ABCDs of melanoma now, as Dr. Reed alluded to. Screening, you could screen yourself, more commonly the dermatologist, and we have a lot of new technology. Here is the Vectra machine, but there are a lot of handheld machines as well that can assist with screening for melanoma. Treatment for melanoma, a combination of surgery, immunotherapy, or surgery, systemic therapy, and radiation. So the standard of care for stage 1 and 2 melanoma is something called wide local excision, where we excise the melanoma with a specific margin. That margin depends on the depth of the melanoma. Of course, early stage prognosis is excellent. What is a wide local excision? Well, even when you see a small melanoma, when you take the melanoma off, when you remove the melanoma with the appropriate margin, the defect is pretty large. And as you can see from the top line, over here we perform a wide local excision with a rearrangement flap, and on the right side you could see how it's closed at the end. The middle row, we use a skin graft. We take a piece of skin from another part of the body, like the thigh, and we shave it off, and then put it to cover the defect in the middle. And the last row, you could see a melanoma on the scalp with its defect, and then the rearrangement flap to close the lesion. Over here are two rows. You could see both rows. These are melanomas near the nipple. And of course, we want to keep cosmetically, we want to keep the nipples where they are, and therefore two different types of rearrangement flaps to close these lesions. Now, when you see these rearrangement flaps now versus when you see them in 6 months, they're very different. Once they heal, most of them look excellent cosmetically. And lastly, here's a melanoma of the arm with its defect and closure, and a melanoma of the foot with its defect, and this one actually closed by itself. We can't talk about melanoma without talking about sentinel lymph node biopsy, which is extremely important. These are a sampling of lymph nodes. What that means is that we look at what, if your melanoma were to spread, which lymph nodes would it spread to first? And this we could figure out with something called a sentinel lymph node biopsy, and we sample these lymph node or lymph nodes. Who do we perform this operation for? We perform this operation for patients who are at high risk for lymph node metastasis, and that usually equates to a melanoma that's at least 0.8 millimeters, so less than a millimeter, 0.8 millimeters thick, or less than 0.8 millimeters thick, but have aggressive features like ulceration. And if you do have a sentinel lymph node that is positive for metastatic melanoma, then you will need immunotherapy. In the olden days, we used to do complete lymph node dissections, meaning we would remove all the lymph nodes in that basin. But now, due to the advent of immunotherapy, and as Dr. Berkowitz said, how good immunotherapy is and how it increases survival, we use immunotherapy as opposed to completion lymph node dissection. And the reason, because we found that all the patients that we take back for a completion lymph node dissection, over 70% of them have no more disease. So for stage 1 and 2A of melanoma, which are considered low-risk melanomas, we just do surgery alone. But stage 2B and 2C, which are considered high-risk melanomas, even if the sentinel lymph node is negative, we still give a year of immunotherapy. These are patients who either have aggressive features like ulceration, or their depth of their melanoma is a very deep melanoma. And once again, any sentinel lymph node that is positive, we give a year of adjuvant immunotherapy. Metastatic disease, usually we treat with systemic therapy like immunotherapy or targeted therapy, but we could use surgery if the patient has an urgent or an emergent problem like bleeding or obstruction. How about recurrent disease? Patients that have disease that comes back in the same area or in the vicinity. This is called in-transit disease or satellitosis. There are many treatments like surgery. If there are a few lesions, we could do surgery. However, if there are too many, like you see in this picture, we could use something called intralesional TVEC, systemic therapy, or perfusion therapy. What is perfusion therapy? This is either something called hyperthermic isolated limb infusion or limb perfusion, where we isolate the limb and we give perfusion to that extremity with the cancer. And because we're isolating the limb, i.e. with a tourniquet, the chemotherapy, usually melphalan, does not go systemically and cause any systemic issues. Then there's something called TVEC, which is a modified herpes simplex virus, which we inject into these in-transit or satellite lesions, and we use it until the lesion goes away or if the lesions grow. There actually has been a study of TVEC versus systemic therapy versus radiation therapy for in-transit disease or satellite lesions, and TVEC actually has the most complete responses. Prevention, like Dr. Reed explained, avoid tanning beds and avoid the sun. So at least once a day I get asked by a patient, is melanoma a cancer? and I also get asked by many patients, I thought melanoma is only on the skin, but as you can see from these pictures, melanoma can spread to almost any organ in the body, including the brain, the bones, as well as the stomach, colon, gallbladder, spleen, basically almost any organ in the body. So in conclusion, melanoma is a cancer and can be very aggressive locally and metastatic. If you're concerned about a mole, see your dermatologist. Stay out of the sun and or protect yourself with appropriate clothing and sunscreen. Surgery is still the standard of care for melanoma and the majority of skin cancers. And there have been multiple new treatments recently, especially immunotherapy and radiation options. Thank you.
Thank you, doctors. Well, everybody get out your sunscreen because to the audience, do we have any questions? Each of the speakers, each physician was so thorough. I think they probably answered all our questions but might have raised a couple. Anybody have any questions? If not, I want to remind everyone, first of all, thank you to each of the speakers. The amount of research and work that goes into a presentation like this, each of you make it look so easy, but I know it's a lot of work and a lot of time to do this. So we appreciate your expertise and your time. We're very, very, very grateful. And this particular presentation was very enlightening. Yes. Tricia said, great presentation. I will be sure to use my sunscreen. I think I'm gonna check the expiration dates on mine when I go home. But I want everyone to know that this lecture was recorded. So if you want to go back and look at it again, you will be able to. And if you'd like to share it with family and friends, which I feel that there's a lot of opportunity for that, especially for those of us living in Florida, that we may want to share this. The editing will be ready next week. So Lee will send out an evaluation, which we appreciate if everyone would just take a minute and complete the evaluation. Along with that, she can send you a link for the lecture if you'd like to view it again. And the evaluations help us. You can also add any comments or any other topics that you would like to hear about. So we appreciate the speakers. We appreciate everyone who has joined us today. And our next lecture for May, and I just have to say, it's hard to believe that we're already at the end of May, but on May 21st, we will have a presentation from our nutrition series, and Katie Lauterbach will be our presenter, and it will be entitled Fueling for Exercise. Thank you, doctors. Thank you, everyone, for joining us, and everyone have a great afternoon and weekend. Bye-bye. Thank you.